Welcome back to the deep dive. We're here again to, cut through the noise and really get into the sources.
Yeah, that's right.
And today, we're tackling something pretty challenging, a topic that's really tested healthcare professionals, researchers for decades.
A sensitive one.
Exactly. The question is it truly inappropriate, ethically, practically, to study people who are very near the end of life?
It's a huge question, and one that's often been answered with a default, yes, it's inappropriate.
Right. But we're diving deep into a really important paper today. It's Hopkinson et al. From 2005.
A pivotal piece of work.
It really is. Because it doesn't just ask if research is possible with this incredibly vulnerable group. It actually shows how. It explores new ways, new methodologies for palliative care research.
Yeah, it really broke new ground.
So our mission today is to unpack how they did it, how they managed to conduct research ethically and successfully, revealing insights that, honestly, they kind of reshape how we think about patient autonomy and research itself. Okay, let's unpack this.
Let's do it.
So for a long time, everyone's known there's this big pressing need to strengthen the evidence base for palliative care. That vital field focused on quality of life for patients and families facing these life-limiting illnesses.
Absolutely critical work, but the research.
Yeah.
Yeah.
Right. Historically, the research just hits a wall. Instead of hearing directly from patients, studies often had to rely on proxy information, so info from doctors, nurses, family members.
Which, has its place, it's valuable information.
Sure, but it's got clear limits, right? So that's
Yeah.
what you want to understand the patient's own experience, their fears, their concerns, what they're going through.
You miss that direct voice, and that's crucial for tailoring care effectively.
Totally. And what's so striking here, and you mentioned this, is the contrast with other patient groups.
Yeah, it's fascinating. I mean, you look at studies with people needing, say, home respiratory support, or even adolescents talking about HIV status. You see really high response rates, 80%, 86%.
These are folks dealing with serious health issues, too.
Exactly. But then you look at palliative care research, historically, the recruitment rates just plummet, like 17% for some survey work, maybe even 9% for outcome studies.
That's incredibly low.
It is. And the result is tiny sample sizes, often not representative, which means trials aren't viable. We end up lacking that robust data we desperately need.
And, you can understand why these challenges exist, can't you? There are very real practical hurdles.
Absolutely.
Patients are often extremely frail. Their condition can change, hour by hour sometimes.
Rapidly, yeah.
And imagine trying to focus when you're dealing with pain or just overwhelming fatigue or anxiety.
It makes filling out a long form or sitting for an interview incredibly difficult, sometimes impossible.
And then there's the human side from the care team. The doctors, nurses, the family carers, even the researchers themselves. They often step in to protect the patient.
That protective instinct is strong.
Yeah, they want to shield them from what feels like an extra burden. They genuinely don't want to add to someone's suffering at that stage.
Precisely.
Right.
And that leads directly into those ethical objections, the ones that really held back research for so long.
Right.
The core belief was essentially that the potential harm just outweighed any possible benefit for someone nearing the end of life.
Why put them through it if there's no immediate gain for them?
Exactly. Why use up precious time and energy? And then there's the discomfort of asking about really distressing things, symptoms, feelings, especially if you, as the researcher or clinician, can't offer an immediate fix right there and then.
That must be incredibly awkward, ethically challenging for everyone.
It creates significant discomfort, absolutely.
Okay, so given all that, these massive practical and ethical barriers, how on earth did Hopkinson and the team manage to break through? What was the big idea? What changed?
That's the crucial part. They proposed what they called a context-specific participatory approach.
Context-specific participatory.
Yeah, and this wasn't just tweaking the old methods. It was a fundamental shift.
Yeah.
Think of it like changing where the power lies in the research process.
Right.
Instead of the researcher being entirely in control, dictating everything, it becomes more of a negotiation, a dynamic process, mutual learning, with the researcher almost acting like a facilitator.
Interesting. Shifting the power.
Exactly. And they applied this to study something really sensitive, weight loss, and eating difficulties in people with advanced cancer.
Right. So it's about empowering the patient, putting their immediate situation, their context, right at the center of how the research is designed. Yeah. How did that actually work in practice?
Well, it started with real collaboration. This wasn't research done to people, it was done with them.
Okay.
The study involved clinicians, actual service users, patients, and carers, academics, and a multidisciplinary steering committee all working together.
So everyone had a say from the start.
Pretty much everyone's expertise was valued,
Yeah.
and that led to key decisions in the context-specific design. Well, one big one was acknowledging how overloaded healthcare staff are. So to minimize their workload, they decided to focus the study on people living in their own homes. They specifically excluded patients in acute hospital settings.
Ah, okay. So not a compromise on quality, but a practical choice to make it feasible.
Precisely. It was about working within the realities of the palliative care setting.
And did that thinking extend to the research tools themselves, like the questionnaire?
Absolutely. The questionnaire itself was developed with input from service users. They advised on whether the questions felt right, if the content was appropriate.
That makes a huge difference.
It does, and they deliberately kept it brief, maximum 10 minutes to complete. Used simple yes-no answers where possible. Think questions like, I am concerned about my weight. Clear, easy to respond to, even if you're feeling unwell.
Minimizing that burden again.
Exactly. And the data collection was also really flexible.
How so?
It was distributed by 14 specialist nurses who knew the patients, but patients had a choice. Return it by post, privately, or give it back to the nurse.
Choice is key.
Yes. And crucially, the main researcher kept up a constant one-to-one dialogue with those nurses, like checking in, seeing what problems were coming up, getting that real-time feedback.
So it wasn't just set and forget. It was dynamic.
Totally dynamic. That dialogue meant they could adapt as they went. If new barriers popped up, maybe a family member was hesitant, or a nurse felt it wasn't the right time to approach a specific patient, the criteria for who was included or excluded could actually evolve during the study.
Wow, that's unusual. Usually criteria are fixed up front.
Right. But here they realized, for example, that with patients at home, the nurse often needed to gently negotiate consent, not just with the patient, but also get informal agreement from family members.
That's a nuance a traditional rigid approach might completely miss.
Exactly. It's being truly context sensitive.
Okay, so they put all this thought, this collaboration, this flexibility into it. What happened? Did people actually take part? What did the numbers show?
The numbers are honestly pretty stunning, and they really challenge those old assumptions.
Lay them on us.
Okay, so out of 345 patients under the care of these nurses, the nurses judged 272, that's nearly 79%, as potentially eligible.
So most people weren't immediately ruled out.
No. Only a small group, about 73 patients, were excluded for clear reasons already in a hospital, sadly died before they could be approached, or unable to give informed consent.
Okay. And of those eligible?
Of the 272 eligible, 233 were actually given a questionnaire. That's 2/3 of the total caseload approached.
Right. And the big question, how many came back?
This is the kicker. 199 patients returned the questionnaire.
199 out of 233.
Yep, that's an 85.8% response rate.
86%?
Yeah.
That's huge, especially given the historical rates of like 9 or 70%.
It's night and day. It's a powerful, direct rebuttal to the idea that these patients can't or won't participate. It just shows if you approach it right.
They will engage. And was the sample representative?
Yes, crucially, they checked. No significant differences in gender, age, or cancer type between those who participated and those who didn't, or between the different study locations. So they got a good representative sample.
That's so important for the findings.
It is. And just to underscore the reality here, they followed up. Within 3 months, 42% of the participants had died.
Wow.
And 18 months later, only 20% were still alive. It just highlights how frail this population is and how vital it is to capture their experiences when we can.
That context is sobering. Okay, beyond the numbers, what about the human side? The nurses who were doing this work on the ground, what did they think?
Their feedback was really interesting, overwhelmingly positive, actually.
Really? Even with the potential extra work?
Yeah, many said it was less demanding than expected. One nurse was quoted saying, "It didn't create a lot of extra work. I thought it might."
That's good to hear.
And they were genuinely amazed by the high response rate, just astonished that very sick patients were so willing. Another nurse said, "I'm just really amazed. I was actually quite surprised because I felt a patient was quite poorly, but she was really keen."
That speaks volumes, doesn't it? Someone very ill being keen to take part.
It completely reframes things. And the nurses noticed patients were often enthusiastic about contributing, about helping others in the future.
A sense of altruism, maybe?
Seems like it. And there was an unexpected positive. Distributing the questionnaire actually opened up conversations about symptoms like weight loss. It raised awareness. Some felt it was even therapeutic for the patients and families.
So the research process itself had a benefit.
In some cases, yes, seen as a beneficial outcome of the study. Nurses also said they enjoyed being involved, feeling like they were helping to develop practice, contributing to the evidence. One said, it's actually quite nice to be part of that.
That's fantastic, but surely it wasn't all smooth sailing. Were there challenges for the nurses?
Oh, definitely. And it's important we acknowledge those. Practically, just remembering to carry and hand out the different bits of paper letter, info sheet, questionnaire could feel like a hassle, a bit burdensome.
Yeah, juggling paperwork.
Exactly. And some found it tricky to set up a good system for tracking who they'd approached. Also, feedback suggested patients didn't always read the detailed letter. Maybe simpler info is better.
Okay, practical stuff. What about the emotional side? You mentioned the sensitivity earlier.
That was significant. Nurses weren't necessarily used to initiating conversations specifically about weight loss or eating problems, so they felt some emotional discomfort, some anxiety about raising these sensitive topics.
Especially if the patient was clearly dealing with other big things.
Right. Like, as one nurse put it, especially the fact that they might be dying, it made them uncertain about when was the right moment to introduce the study. They often preferred to approach patients they knew well who weren't already very distressed.
That makes sense. Were there worries about upsetting families?
Yes, some concern about that. One nurse worried it could reopen old wounds for the family.
That's a very real concern for anyone providing care.
Absolutely.
But you mentioned earlier, sometimes the discussion was helpful. There was a counterexample.
Indeed. There was one instance where discussing the questionnaire made a patient more aware of the fact that he was actually losing a lot of weight, and both the patient and the nurse felt that discussion was very useful.
So even sensitive topics, handled correctly, can be beneficial.
It seems so. It's about the context and the approach.
Okay, so taking all this and the amazing response rate, the mostly positive feedback, the challenges too. What's a deeper reason this approach worked so well when others hadn't? What did they really unlock?
I think the core insight is enabling the methods to be truly tailored to the philosophy and practice of palliative care. That phrase they used, context sensitive, is key.
Right, not imposing a generic research model.
Exactly. This approach valued different kinds of knowledge. You had the researcher bringing the technical expertise, coordination, but you also had the healthcare professionals as the clinical experts, the ones best placed to make those sensitive judgments about timing, about patient appropriateness.
A partnership of expertise.
Yes, and the flexibility wasn't a weakness, it actually made the study stronger. Supporting nurses, letting them integrate it into their usual practice as much as possible, it enhanced the rigor, didn't compromise it.
And the simple questionnaire helped too, presumably.
Massively reduced the burden. And because it was developmental, this collaboration, this negotiation, the nurses could flag issues and adapt throughout. It's a model for real-world research.
Okay, and ethically.
Yeah.
How did this shift things?
It fundamentally challenged that old belief that research participation is always harmful or risky for people at the end of life. You see, in clinical practice, beneficence doing good for the patient is paramount, of course. But in palliative care, respect for individual autonomy, the patient's right to choose becomes just as critical, maybe even more so.
It aligns with that idea of helping people live until they die, right? Giving them agency.
Precisely. So the argument flips. Maybe excluding these patients from research, based on our assumptions about protecting them, is actually unethical because it removes their right to choose.
Taking away their voice, their autonomy.
Exactly. And what happened when this study offered the choice?
The vast majority said yes.
Overwhelmingly, yes. They elected to participate, which, as other studies have also found, suggests many patients want to contribute to help find solutions for others. Debunks the whole they don't want to be bothered idea.
So participation itself could be positive.
It seems it can be life-affirming. It gives value to their experience, offers a chance to make a difference. The research almost became, as the paper puts it, an integral part of care with its own therapeutic value because it prompted these important clinical discussions.
And they managed concerns about coercion, too, like patients feeling obligated.
Yeah, they thought about that. Allowing postal returns gave privacy. Patients could discuss it with family. Nurses weren't told who specifically responded from their caseload. And using the nurses, who patients knew, felt less intrusive than a stranger researcher or a cold postal survey.
Makes sense. So wrapping this up, this deep dive into Hopkinson et al., 2005, It really shows something powerful, doesn't it?
It really does.
It shows it is possible. You can develop research methods, context-sensitive, participatory, that are feasible, that patients accept, and that are incredibly successful in palliative care.
It directly challenges those decades of assumptions that basically sideline the patient's voice.
Yeah, assumptions that stopped us understanding their experience and strengthening this vital area of healthcare. It's just a vivid reminder, isn't it? When research adapts to the people and the context, instead of imposing itself.
You get powerful results. You empower the people you seek to understand, you uphold their dignity, their autonomy, and you get better data.
So what does this all mean for you, listening?
Well, I think it's about recognizing that vulnerability isn't the same as inability. It's not an unwillingness to contribute.
Right.
It's about designing research, maybe even other interactions, with respect for choice, for lived experience right at the center, realizing that how we ask, how we engage can be just as important as what we're asking.
Absolutely. Which leaves us with a final thought to mull over. What other areas, maybe in research, maybe just in life, could benefit from this kind of participatory, context-specific thinking? Where else are we making assumptions about who can or should be heard, and how could challenging those assumptions actually help us advance knowledge or just connect better?
Something to think about.
Definitely. Thank you for joining us for this illuminating deep dive.